Good morning. Welcome to today's presentation. My name is Dr. Enudi Sylvester. I'm a senior registrar in the department and we'll be presenting on medically unexplained or undifferentiated symptoms. We'll be using these outlines. We have a case scenario that we're going to look at, then go through to the introduction, epidemiology, risk factors associated with MUS for short, categorizing MUS, skills in family medicines for management of MUS, other helpful approaches, 10-step protocol for the management of MUS, then differential diagnosis, conclusions, and references. So this is the case presentation. You can see the conversations between patient Alice and Dr. Jane. So the patient starts bad. It's been bad this week, especially in my stomach. I just don't know what is wrong. I've been so fed up with my boyfriend. While patient is saying that, look at what is going on in patient's mind. She doesn't know how bad this is. There has to be something wrong with me. And the doctor can responding, well, there isn't anything wrong according to all the workups. But if you sound like you're having a flare up, are you still taking the Elavil? Patient response, yes, but it is not helping much. I still have so many bad days. And patient is thinking in her mind, I don't think the meds will help, but maybe a scope will show something. Doctor's response, you are going to be okay. We have tried other meds that haven't really worked. You could try upping the dose or ordering another scope. And the doctor's mind is going, I don't know what to do for this patient. Patient's response, I don't want to try changing the dose. I've had bad experiences with side effects. I would try another scope though. And the patient's mind, she's thinking at least she doesn't think I'm crazy or it is all my head, in my head. Otherwise, she wouldn't order the scope, right? And doctor's response, I'm not sure if it will reveal anything, but it is worth a try. Maybe something will be different this time. And in doctor's mind, it won't show anything, but it is something, and I have more patients to see. Now, this is kind of the cases that we see, and this kind of conversation goes on in our mind. Sometimes you look as though you are weary of the patient, you don't know what to do for the patient. Patient is demanding. You don't know where or how to place the patient's symptoms. You have tried almost everything you know as a doctor, and you can't seem to tie patient experience with what you know in medicine. So this is a case of medically unexplained or undifferentiated symptoms. So symptoms are medically unexplained if adequate investigations fail to identify a clear and plausible physical cause for their occurrence or the associated level of impairment, and they cause clinically significant functional disabilities or distress, and they cannot be solely attributed to diagnosable anxiety, depression, and psychosis, meaning it has to be a diagnosis of exclusion. Note the important component of the definition. You have done adequate investigations that fail to identify a clear and plausible physical cause of the occurrence or the associated level of impairment, and they cause clinically significant functional impairment in this patient. I must rule out anxiety, depression, and psychosis in this patient, according to Bowen et al. 2004. As a form of introduction, the term MUS for short is applied to a clinical presentation which cannot be explained through contemporary medical, anatomic, physiologic, and or scientific methods. Medically unexplained symptoms are persistent bodily complaints for which adequate examination does not reveal sufficient explanatory, structural, or other specific pathology. These patients are a challenge to medical professionals. The term used to describe such symptoms, medically unexplained symptoms, or functional somatic symptoms, that is another name for it. Functional somatic symptoms are purely descriptive and do not imply psychogenesis. Medically unexplained may mean symptoms are not real, or they're in patient head, or they are real. Many of the affected patients do not receive a correct diagnosis and undergo numerous fruitless investigations and attempt at treatment. And this is one of the things you watch out for as a family physician, over investigation when it is not necessary, when you know that it's not going to reveal much. Now, the scope of the definition covers three things. One, there's no identifiable cause, subjective experience, then there's an overlap with other medical conditions. Usually, you have some psychological conditions like depression, anxiety, and other related conditions. Then the common symptoms you find in medically unexplained symptoms, we have pain, including headaches, back pain, and muscle pains. You've treated malaria, you've done everything, take analgesics, but pain seems to persist. Then unnecessary fatigue. You have done everything, check anemia, check other things. Patients seem to have consistent fatigue. Then dizziness or lightheadedness, numbness or tingling sensation. So in others, some people will use what crawling sensation. I have things crawling over my body, over my head, my body, every part of my body. Chest tightness or palpitation or rapid heartbeats. And usually we've done ECG, everything seems to be fine. No BP, no ECG finding suggestions of arrhythmia. Then nausea or indigestion, blackout or limb paralysis. Now, very important point. The narrow focus on the somatic aspect of a complex problem may reinforce their concern about having a physical disease, contribute to the development of chronic disablement, and cause healthcare costs to become excessive. It means that there is a temptation for you to want to tie every symptoms to a physical pathology. So that is why many of them, before they present to you, have gone through investigation, so many investigations, gone through different hospitals, see different doctors. And if care is not taken, you are just be another doctor that will repeat the circle. And at the end of the day, you won't be able to help patients. Patients will have spent more money and all that. Then many times we want to evaluate patients linearly, while the problem is complex and interwoven. So sometimes medical conditions are not straightforward. Hence, they need to evaluate psychosocially. So this is what makes us family physician. The normal physician will just think pathogenesis and pathophysiology. But what makes you a family physician is your ability to incorporate the psychological and social component of disease in the management of patients. Another important point to note is these symptoms are not faked by patients, and they are not a sign of weakness, challenges for the and there are challenges for the healthcare professionals, and there's need for comprehensive assessment. So then three key features of medically unexplained symptoms. One, there is increased disability in these patients, there's poor quality of life, and increased healthcare costs. Unexplained or undifferentiated problem present often in family practice. It is expected that the family physician should be a skilled diagnostician, highly trained in managing undifferentiated problems. Uncertainty in clinical decision making has been linked to adverse outcome in patient care. Uncertainty in clinical decision making has been linked to adverse outcome in patient care as a form of epidemiology. 10 out of the most common problems presenting in primary care account for 40% of the visits. Biological causes are found in only 26% of cases. Prevalence of 18% in the United Kingdom. Globally, 25 to 50% of patients present with MUS, and MUS costs about $250 billion per year in the United States of America. Then there are risk factors that associate patients with medically unexplained or differentiated symptoms. The cause and the management of undifferentiated problems may become clearer through history examination or investigations, or may become clearer over time as a disease progresses, so-called progression of disease. Sometimes some at the early stage of the disease, you might not know exactly what is wrong with patient, but if you give it time, the full manifestation of the disease, with the full manifestation of the disease, you'll be able to point out what is going on with patient. So some undifferentiated problems remain undiagnosed despite thorough assessment and investigation. And sometimes a physician, you have to be at peace to this fact. If you have done everything medically possible to find out what is wrong with the patient, you're not getting any. It is sometime you should know when to draw the curtain. Many have psychological origin. So the more we understand this, the psychological component of it, the better it will be for any physician managing such patients. Some may have obtained some treatment before presentation, masking the natural cause, which is true. Most patients will have taken so many medications and alter the clinical presentation or the natural history of illness. Long-term condition with anxiety and depression. So many of these patients have underlying anxiety and depression. Of course, there's also childhood adversity or abuse, more common in women, then certain personality disorders. Then recent infections, current physical illness, severe illness, or death of a close relative. Categorizing medically unexplained symptoms sometimes can be acute, semi-limited, or minor, and persistent or impairing. So these are the symptoms. Skills in family medicine that can be employed in the management of medically unexplained symptoms, offering solutions to undifferentiated problems in the context of a continued personal relationship with individual and families, preventive skills like identification of early departure from normalcy, using time as a diagnostic tool, seeing patients and giving early follow-ups. Then we have therapeutic skills, doctor-patient relationship, continuity of care, whole person medicine, that is holistic care. Not just looking at patients linearly, cause and effect, holistic care. We also have palliative care. Sometimes this is all you do for patients, and you need to assure patients so that they will stop the doctor shopping and continue spending of endless cycle. Then as a family physician, so one you want to do is resource management skills. So you want to help them to conserve their resources from over investigation, especially if they have done all those investigations before and there seems not to be an identifiable cause for the disease. They also have research skills, good reservoir or bank of research subjects and material. So family physician also, this patient like this can be an avenue for you to write a case or even do research and find out something new that might help in the long-term management of such patients. Then as a family physician, one of the skills you need is good communication skills are very helpful in managing unofficial problem of psychogenic origin. Other Other helpful approaches: a good history involving family and caregiver, examination and investigation, that is evidence-based, as against excess investigation, go a long way in reducing misdiagnosis. The family physician will need to adopt a fail-safe approach and recognize that some symptoms may never be attributed to specific conditions. Patience and commitment to the patient is key. Family physician must be familiar with disease patterns specific to their geographical area of practice, which may help establish local variation in disease presentation. It means that some disease present differently in different environments. So there are varied manifestation of the same disease. So you have to know how disease present in your environment. Familiarity with pattern of serious conditions that must not be missed. So there are pathognomonic symptoms you see in patients, you should know that this is what is pointing to. So as a family physician and a good diagnostician, you should watch out for those and not miss them. Eliciting the patient expectation. This is where one of the things that makes you a family physician, where you fulfill patients, ask for their fears and feelings, the idea, what they think is responsible, and their function or impairment as a result, and their expectation. What do they hope to achieve in this consultation, and guide them properly. Multidisciplinary teams may be required to successfully characterize and manage unrelated problems. Sometimes you need to refer and involve other specialists. Patient evaluation. So how do you evaluate such patients? One, history taken is very significant. So also you want to dwell on past medical history. You want to fulfill these patients, psychosocial history, family assessments. So you have to part of your psychosocial assessment of this patient. You want to assess for family functions and the family medicine tools you can use like ABGA, genogram for in case if there is anything familiar, echo map, and family circle. We are trying to assess patient resources within the context of the family and the environment. Scream and timeline. Something timeline helps you to place the symptoms. Is there something happening each time patient comes down with this particular illness? Is there any stress so you can define based on timeline of events? Then general physical examination, investigation and management. So we come to the management aspect. The management of patients with MUS can often be frustrating. However, it is essential to find a balance between an adequate assessment of the underlying cause for the patient's symptoms and concerns. Also, avoiding excessive investigation that may cause further distress for the patient. So your aims, the aims of management. One, you want to decrease, of course, the three key features of MES is that increase disability, reduce quality of life, and increase healthcare costs. So your management team should address these three things, which are to decrease patient disability, improve patient quality of life, and reduce healthcare costs. 10-step protocol for management. Acknowledge distress, elicit the patient perspective, focused examination, specific reassurance, discuss alternative explanations, consider medications when necessary, general coping techniques, specific stress solution, discuss responsibility and approach for review. So we'll see how these 10 steps will help us in the management of MES. So the first is to acknowledge distress. So as a doctor-patient relationship is key, it's a key part in the management of this patient's problem. It helps to develop rapport and the patient believes you are doing your best for them. So one of the things you can do is for let patients know that you care about them. The doctor must listen carefully to the patient's problem and be empathetic. So your body language is important. You must not be saying that being dismissive or patient passive that you just want this patient to get out of my sight. One, elicit patient's perspective. So you want to ask the patient, what do you think is going on? This is where FIFI comes in. And you also want to elicit hidden agendas in case of yes, malingering and fictitious disorder. So these are part of the differentials we have to roll out. Focus examination. Doctor must do a thorough physical examination and do appropriate investigation, especially in the elderly. Very important in the elderly. Help to exclude underlying illness at the same time helps to reassure patients. So that is another thing. The fact that you taught patients something goes a long way to reassure them. It has a therapeutic effect. Specific reassurance. Acknowledge and indicate commitment to understand the patient concerns and symptoms. Encourage an open and honest transfer of information that will provide a more comprehensive picture of the patient's concern and medical history. Show commitment to allocate sufficient time and resources to resolve the patient's concerns. So if we are to manage an MES case, you have to be, sometimes it is time consuming and you have to also do your best to manage time and be realistic with what you can do. Avoid open skepticism or disapproving comments in discussing the patient's concern. So it cannot be seen as dismissing the patient. Discuss alternative explanation. Explain to the patient the complex relationship between the mind and the body. So they say the brain in physiology is the mind in psychology. It means that the mind or the brain controls the body, and a stress in the mind can give a bodily symptoms. The doctor should try to use the patient understanding of illness to explain their condition. Consider medication. Not every ill patient will need medication. Patients with anxiety disorder, depression should be treated appropriately with antidepressants at therapeutic doses. General coping techniques. Behavioral therapy may be very effective in helping patients with MUS. We can encourage them to make more short-term goals and regularly evaluate themselves. Behavioral techniques for MUS. We have CBT, relaxation and mindful techniques, exercise and physical activities, social support and emotional expression, self-management skills, reframing and reattribution. We are going to look at each of these, some of them actually. Key principles for behavioral techniques for MES. You want to focus on the present, so you don't want to go on a hunting spree of the past. Just get specific past medical issue that helps you to arrive at your conclusions. The patient-centered approach and collaboration with healthcare professionals is very key. Benefit of behavioral techniques. One, it reduces symptom severity, improve quality of life, enhance coping skills, and improve doctor-patient relationship. Specific stress solutions. Help patient find own solution to problem. Help patient find own solution to problem. Help them decide on ways to coping with stress that can be resolved. So it's part of patient-centered care, patient participation and decision making concerning their health. Discuss responsibility. The doctor should aim to take emphasis away from searching for a cure. The patient needs to come to terms with their symptoms and deal with the symptoms as they are. This has the effect of reducing stress. Once patients can come to rest that sometimes they cannot find the cause of what they are going through, it stops them from going on a hunting spree for cause. Then appointments review. At each patient visit, the clinician should consider the following. Ask if there are unaddressed, unresolved concerns, summarize and explain all test results, schedule regular brief appointments, explain that outstanding results and consultation will be reviewed during follow-up visits, offer to include any concerned family members or significant other in the follow-up visit. Then the role of alternative medicine in MUS. One, because of this presentation, acupuncture may be needed for those with low back pain, yoga meditation for patients with anxiety, chiropractic for patients with chronic back pain and spine pain. We also have homeopathic, naturopathic, and massage therapy. All these alternative medicine that can be employed in the management of MES. Things to note, because of the health-seeking behavior of patients with MES, family physicians should be aware of liver and kidney problems from consumption of unsafe herbal medications, polypharmacy from multiple prescriptions, and differential diagnosis of MES. We have somatic symptom disorder, functional neurologic disorders, chronic fatigue syndrome, irritable bowel syndrome, fibromyalgia, illness anxiety disorder or hypochondriasis, factitious disorder of malingering, other psychiatric disorders. So this is a classification of differential diagnosis. Most of them are somatic disorders, somatoform disorders. Then this is like a brief explanation of each of them. So functional somatic disorder, this disorder involves neurological symptoms such as paralysis, numbness, seizures that cannot be explained by brain damage or physical abnormalities. Chronic fatigue syndrome or myalgic encephalomyelitis is characterized by persistent fatigue that is not relieved by rest or accompanied by other symptoms like sleep disturbance, cognitive difficulties, and pain. Irritable bowel syndrome is a functional gastrointestinal disorder with symptoms like abdominal pain, bloating, altered bowel habits, often without underlying structural abnormalities in the digestive system. So patients with this kind of presentation, they might benefit from referral to gastroenterologists. Fibromyalgia is a chronic pain condition characterized by widespread musculoskeletal pain, fatigue, and other symptoms like sleep problems and cognitive difficulties. We also have somatic symptom disorder. This disorder is formerly known as medically unexplained. So some authors consider somatic symptom disorder as MES. Involve physical symptoms accompanied by excessive thought, feelings, or behaviors related to health concerns. Illness anxiety disorder or hypochondriasis. This condition is characterized by preoccupation with having or acquiring a serious illness even when medical tests are negative. So patient can think that he has a rotten stomach and not that. And you have done every investigation, but patient keep on holding on to it and feeling. So conclusion, people want to be taken seriously. Show you believe them. Doctors can make a difference to the patient's well-being even when their symptoms are unexplained. Sometimes the only therapy needed may be the strength of your doctor-patient relationship. Continuity of care and long-term relationship helps. Be explicit about your thoughts, your uncertainties, and your expectation of referral to specialist care. So these are my references. Thank you for your time. Okay, these are like questions that you can go through to test your knowledge of the topic. Thank you so much.